Thanks. Good afternoon, everyone. Thank you very much for inviting me to talk this afternoon on a subject that's very close to my heart. Having done a fellowship in Newcastle about, that makes me sound old actually, but nearly 15 years ago maybe now, with the muscle team. This was an area that I knew very little about, sort of endocrine in DMD generally. But now we've come to appreciate that we see these, really from when they're boys to young men with DMD very regularly in our endocrine clinics. And there are so many subjects that we now have to cover in one clinic appointment. It actually has become so much of a challenge that we have set up our own sort of DMD multidisciplinary endocrine clinic now in Newcastle. And I could talk about all these subjects because I think they're all really, really important and deserve equal stage. But obviously this afternoon they've asked me to talk specifically about bone pain and pubertal delay. It's really difficult to pitch these talks at the right level for everybody, because I appreciate that some of you are very early in the journey, whereas others will be experts and probably know just as much as me, if not more, about the latest, the studies that have come out and things. So feel free, it's quite a small room. If you want to ask questions during it, I don't mind at all if you just want to pop your hand up. Or obviously if you'd rather leave them to the end, that's fine. But if something isn't making sense and you're falling asleep, please, either do something to bring my attention, or just ask so that I can explain it in a bit more detail. So first we're going to talk about bone pain and fracture. And this, I know you're not supposed to have favourite patients, but he is probably one of my favourites because I met him very early on, and this is just an example of the kind of patient that we see coming to our clinic now. So because I first met this patient a long time ago, he presented relatively late, and I would hope that actually we would now have contact with somebody like him earlier on in the journey. But he presented age 13 with delayed puberty. And by that point, he was on a good dose of prednisolone and had been since the age of about 5. He was on some vitamin D, and because we used to give an oral bisphosphonate, which I'll talk about later on, in Newcastle, very early on, he'd been on that since the age of about 6, 7 as well. So he presented with delayed puberty, and this is a typical growth chart that we see. There's actually 2 plotted on here, but the one I wanted you to look at is the blue line. And hopefully you can see that he started off small anyway, and then at the point A on the graph, that's where he starts his steroids, and you can see the tailing off on that growth chart. So by the time we saw him when he was referred in at point B, he's way below the bottom of the growth chart. And then we started some testosterone treatment on him. And he was actually one of the ones who was in the testosterone study that we ran in Newcastle, which I'll talk a little bit about later on. So just after we'd started that testosterone on, unfortunately, he knocked his leg, really simple bump against the side of a chair at school, and had the first of several fractures. So he just had an undisplaced fracture, which you can, there's the pointer there somewhere. You can maybe see there, just, it's not a very good pointer, but just at the top there of his, sorry, no, on this one it's just there on the top of his tibia. And then he went on, age 13 and a half, to have a distal femoral fracture, which again isn't projecting particularly well, but you can just see it there, and he needed pins in that. So 2 fractures, in the space of a year there. He continued to have his testosterone, tolerated it very well, went through puberty, and then obviously we were still seeing him regular. But when he came into clinic when he was 17, complaining of really bad back pain, really stoical young man by this point, and just said, I'm really struggling with it. And when we looked at his spine, we were doing regular spinal imaging, but even just in the space of a year, he'd had these new onset vertebral fractures. So you can see wedging there, you can see wedging there, and actually the bottom of his spine wasn't particularly great either. So we started him on some IV bisphosphonate at that point, which again we'll talk about later on. But it's interesting as well to look at his hand x-ray here, because we do this to look at bone age for the simple reason that there's so many bones in the hand, we get a lot of chances to look at the growth plates. And what you can see here is that these, basically the gaps between the bones are really quite big still. His growth plates are still quite open, whereas you would expect somebody at 17 and a half, to have fused their bones, not to be growing anymore. And his bone age was only 11. So, huge bone age delay. But you can also see, obviously you're not necessarily familiar with looking at x-rays, but hopefully you can see here all these lines, the sort of the stripy, almost like zebra appearance at the metaphyses here. And those are Harris arrest lines, and that's what we get from bisphosphonates. And I'll talk later on about knowing when to start and when to stop bisphosphonates. And that's one of our concerns, those lines there. So these aren't normal x-rays by any stretch. And so he is now still on his 6-monthly infusions. And actually, because of this bone age delay, he's still growing. And so we haven't stopped those infusions age 21. So this is just the kind of the clinical context, and we still see him, well, he's now unfortunately passed to the adult services, so we're not allowed to see him anymore. But we still see these patients every 6 months because it's really quite intensive treatment that we can still offer at this stage. So there are lots of risk factors for low bone density in people with Duchenne. So as you all know, steroids are probably the mainstay of treatment, and they stabilize muscle strength for a finite period of time, but there are lots of side effects of them, and probably one of the ones which causes the most significant morbidity is in terms of your bones. Because these young men spend less time on their feet, they don't get the same signals through to the muscles signaling to the bones to load up, so they have reduced weight bearing. Just chronic disease generally and an inflammatory status also gives you low bone density. Because there's problems with growth, your bones need to grow to be able to strengthen, and also there's a fine balance between being slightly heavier, which is perhaps good for your bone density, and then once you get onto the heavier side of that, then that becomes problematic for bone density. Delayed puberty, as we'll talk about later, that's probably the most significant thing we can do to help bone health. Nutritional difficulties, it can be difficult in boys with DMD to get enough calcium into their diet. Often they want, very beige food, which doesn't tend to contain calcium, vitamin D. And as I've just said, they're not outside perhaps as much as other boys, so we get reduced sunlight exposure. And with that comes, the challenges of getting enough vitamin D in as well. So you can see here there's a huge spectrum of challenges in each one of these with trying to optimize bone density. And like I just said, we now think the more work we've done in looking at bone density in Duchenne, there are probably two distinct sort of parts of bone health that we need to think about, and those are long bone fractures and vertebral fractures. And the reason we kind of need to think of them separately is it's probably the muscle weakness and the lack of loading, like you can see on the left-hand side here. So every time you contract one of your muscles, either by walking or by lifting something, or even just by standing on your feet, your bones get a signal from your myokines, which are these special sensors in your bones saying, we need to be strong, we need to build up. But obviously, if you've got weak muscles, those signals aren't coming through. And we think that the long bone fractures in Duchenne are probably more related to muscle weakness than steroids. Whereas the vertebral fractures, your vertebrae is a slightly different type of bone, and that's exquisitely sensitive to steroids. So we've probably got these almost two distinct things to think about. When we think about bone, everybody in this room's bone will be in the process of remodeling at the moment. It's a really, really active component of our skeleton. And what happens, I always think of it a little bit like a sort of a builder on a building site. So here you've got your osteoblast, that's the guy kneeling down here, working really hard to build up his bricks in his bone. And equally on the other side, you've got the naughty guy who's on the verge of being sacked, who's trying to chip away and wreck that building site. And he's the osteoclast. So you've permanently got this fight between the builder building up the bricks and the guy knocking down the wall again. So you've got your osteoblasts, which are the build-up bones, and then your osteoclasts, which are the ones that break down your cells. And the reason that's important is because later on we'll talk about different therapies to build up your bones. And we can approach that from two different ways. We can help that osteoblast, or we can try and sack that osteoclast, whichever way, you want to think about it. So firstly, looking at the steroid-induced osteoporosis. So when I'm talking about this, I'm really thinking about the spine and what we can do to improve the spine. And we know that within a first year of starting steroids, we're probably expecting bone density to reduce by up to half, by nearly half, just in that first year. And then after that, the bone turnover slows down. So remember I talked about that fight between the osteoblast and the osteoclast. So initially in that first year, you get that guy chipping away at those bones really, really quickly. But then he sort of starts to realize that there's not a lot more bone left for him to chip away at, and turnover slows down. So what happens in that first year is you lose loads and loads of bone, and then gradually the bone turnover slows down. So you kind of get this big drop, and then you get a plateau, and then it gradually decreases. So that 20% in the first year is really important for us to try and optimize all those other factors in that wheel I showed you to try and prevent that initial loss. But it happens through lots of different mechanisms. So once those steroids start, then calcium is affected at lots of different junctures. So you wee out more calcium, you struggle to absorb it from your gut as much, and then, as I say, you've got those osteoclasts, so that naughty guy trying to chip away at the bone, he can live longer, and then the osteoblasts get killed quicker. So it's basically what we're doing is we're tipping the balance between your building of your bone and breaking down of your bone. So we're tipping it so that the bone is broken down faster. And that's what happens to reduce bone density. And the scary thing is it only takes 10% loss to double your vertebral fracture risk. So if you imagine biting into a crunchy, with all the little holes inside a crunchy, that's effectively what healthy bone looks like, if you biopsy it, cut it down the middle. And that's on the left-hand side there, that's normal bone. But this on the right-hand side here is what you see in the spine after a year of steroid. And it's these big bones. You can imagine if you drop that crunchy bar on the floor on the left-hand side, it would bounce. But if you drop that on the right-hand side, if you hit it at one of those little spindly parts, it would snap. And that's what happens in a vertebral fracture. It takes much less trauma to cause that problem. So like I've just said, fragility fractures are common in DMD, and the pattern of fracture is very different, and I think that's what's important, as most people in this room are likely to be either parents, carers, or know somebody with Duchenne, and at some point you may end up in the emergency department with somebody who's had a fall. And I think the key thing here is to remind, very politely obviously, but whoever is seeing that person, that they are likely to experience a different type of fracture. So, if you've got a healthy young person bouncing on a trampoline, the parts of their body they're likely to break. You get toes, you get fingers, you get your wrists from when you're falling, you get your tibial fractures from being kicked in football, that sort of thing. They're different in Duchenne, and that's the important thing for us to know and to look at, because quite often we get people coming to us in clinic saying, I went to see A&E, but they said, oh, you didn't fall from a great height, so there's no point x-raying it. And they're still struggling with pain. 3-4 weeks later, we x-ray and there is a fracture there. And that's a really important concept here, because the quicker we can get those fractures treated and we manage them in a slightly different way, then the quicker we can optimize that bone health going forward. So at least half of boys with Duchenne will have a fracture before they're 12 of an extremity. So I'm not talking about spinal fractures here. I'm talking about what we call long bones. So, fingers, toes are included in that. The key here is that those fractures can be the thing that knocks you off your feet for good. So if you can get that fracture fixed either operatively, or you can get really good physio quickly to get somebody back on their feet, then that can make the difference between them going off their feet permanently and not. And like I said, in one really lovely study that Shuko did in Glasgow a couple of years ago, she showed that the key places, you can see here, it's not the ulnar fractures, the wrist fractures, it's the femur fractures, sorry, it's not making me all the way. The falls from standing. So, 2/3 of these fractures were falls from this height or less. It's not the 6-foot jump off a wall or the crazy things that some kids do. This, quarter of these were falling from a wheelchair. And this is the important point when you're, going to A&E to say, I know it doesn't sound like much, but please can we have an x-ray? And you can see again, it's femur fractures, which is very unusual normally, because, you imagine your thigh bone is really strong, but the problem is it doesn't have the same strength of bone that, a healthy person would have. And particularly at the distal femur, that's where the problem is. So, just at the top of the knee here, it's a really unusual place to break a bone, in a healthy young person or teenager. But that is what we see. So it's a completely different pattern. And vertebral fractures as well. This is a very old paper, but I find it really interesting because this was a prediction model that this chap used 20 years ago. And he said that after 8 years of steroids, 75% of people would have a vertebral fracture. And still, all these years later, he's pretty much spot on. The difference being, compared to this stepwise, I'm not going to try and use this pointer because it just keeps advancing, sorry, but the difference is you can see at the bottom here, he only starts at 3 years after steroids, but we know that some of those fractures occur, even at the time of the steroids or shortly after. So that's where he was a little bit wrong, but he did very well otherwise from that point of view. And the spine on the right is just a fairly extreme example, and you can hopefully see here, all these bendy vertebrae. I always talk to the patients that I see in clinic and say, imagine you're at a bonfire and you've got one of those giant skewers and you've got those big giant marshmallows that are really common in the US, and you put them all straight in a line on your skewer. What you want in a boy's spine is you want those marshmallows to all be nice and rectangular, all in a straight row on your spine. And hopefully you can see there that I wouldn't be very happy, with those marshmallows. And the problem is that once you squash one marshmallow down, it doesn't have the structure of the marshmallow underneath to hold the next one up. And so what you get is what's called the vertebral fracture cascade. And if you imagine, you need that nice straight column to hold your ribs in place, to hold your lungs in place, to help your breathing. Once you get those squashed, then very quickly your posture can change and your breathing can change and the way you sit in your wheelchair can change, which it can cause really, really severe pain. And actually, they're not traditional fractures as you would think of, that picture I showed before with a bone sticking it out at an angle. But what they are is just quite subtle changes. And this, it doesn't matter the technicalities of this, but this is the way we research grade vertebral fractures. But you can see that you can either have just a mild fracture where it's just a bit tilted at the front there, or you can have a little bit more of a severe one. But then you can also have the problem at the top and the bottom. And then these traditional crush fractures, so you can either just have the middle point goes first. If you think back to that crunchy bar I showed you, so you get where there's the most trabeculae, where there's the most lines of bone, that's where you can squash most easily into a sort of a hole. But you can get these appearing in lots of different ways and shapes, but ultimately they all lead to the same problem, and that's that those marshmallows on that skewer aren't nice and straight anymore, and that's what we're trying to avoid. So I guess the obvious thing is, well, what can we do to avoid, these vertebral fractures particularly? One of the things we thought about a little while ago, and I think I was fairly convinced for a while as well, is that deflazacort might be a little bit, bone sparing potentially. But this is, again, from Shuko's work, and what it appears actually is that the highest fractures possibly are with deflazacort, but actually that there's not a lot of difference between prednisolone and deflazacort. And so what we need to think about is, rather than changing the steroid type, is to try and optimize everything else that goes with it and be really aggressive in our fracture prevention and early management. And it's obvious from the graph here, the dotted line, the dotted blue and the dotted black, those are the intermittent, the yellow line is the intermittent deflazacort and the dotted black is the intermittent prednisolone. What's hopefully obvious is that, the time to fracture is longer in those. But what I'm sure you've all heard about in other lectures and things is we know that daily steroids are associated with the best outcome in terms of muscle function. So this is really a question of, trying to make the best use of the steroids, but equally come in with our armoury to try and help bones from another angle. So I don't think it really matters what steroid type you're on. I think it's possibly a little bit genetic. Some people seem to fare better on pred or deflazacort, but whatever works for your individual patient, then we need to work with that. And this is just showing that again. So this is Michaela and the team, the huge 4DMD study that's just come out recently. And you can see here bone fractures. So there were 6 in the prednisolone group and 7 in the deflazacort group. So it's, fairly consistent data. And then again at the end there were only 3 in the intermittent pred group. So we already knew that there were less fractures in the intermittent group. But again, we knew that the intermittent steroids weren't as effective. So it's all about this balance. So the standards of care, which are actually quite old now, 5 years old, acknowledge that we need to monitor bone health. And what it basically says is, to summarise that, we need to ask about fractures. Have you had any fractures? But we also need to do some spinal imaging regularly. And it doesn't really matter whether that's by an X-ray or by the special software that some centres can use on their DEXA scan. But we need to look at the spine in good detail. If someone's on steroids, at least every 2 years and preferably annually. And as I say, the VFA now on a DEXA is really good, but it doesn't matter. There's no better way of doing it. It's just obviously easier if you can get everything from one DEXA rather than having a separate X-ray as well. And then vitamin D levels, we need to optimise those, and I'll talk about that in a little bit. So we know we need to be doing some monitoring. And then I guess once we've done the monitoring, what can we do to optimise bone health? I've said that it doesn't really matter what steroid you're on. So we need to think about the other things we can do, which is optimising vitamin D levels, optimising calcium, bisphosphonates, like I mentioned before. Puberty is probably the most important thing. And then weight bearing. Like I said, every time, even when I'm just standing up here, there are signals going to each and every one of my bone cells telling my bone to build up. Even if you can get somebody in a standing frame for 5 minutes a day, that is really, really good for your bones. Once you take all weight off your feet, then obviously those sensors go. And the reason standing is so important, rather than just doing arm exercises or something like that, is because obviously your vertebrae relies on you standing up and being vertical to get the sensors to those bone cells as well. So vitamin D, I think everybody's been fairly converted to it now in the world of DMD. We probably 10 years ago, when we used to do an audit, we used to see less than half the patients being on vitamin D, but everyone's great now. Everyone just takes it, and it's brilliant. It's a huge relief, and actually, a lot of the time now, we don't necessarily measure the levels unless we're doing bloods for something else, because people are really good at taking it. It's brilliant. But we know that it's, you need it to absorb the calcium from your diet, but there's also this possibility that it actually helps your muscle strength as well, so this kind of dual-pronged attack. Levels need to be at least 50, and in the general population, your GP would say, oh, we're not bothered if it's above about 30. But for Duchenne, we need these levels above 50, because your bones start to pull away at your calcium under about 50, so you need to have what we call optimal levels. And the problem with that is, in the UK, you can see that grey area at the top there, you'd have to be standing outside, absolutely starkers, for 8 hours a day, every day, all year round. And I certainly don't want to be doing that because I get a bit chilly. But it's impossible to get enough from the sunshine. So even if, they did quite a big survey a while ago, even gardeners don't have enough vitamin D. So, if a gardener can't, then it's really unfair to expect these boys to get enough vitamin D just naturally. Plus, when you add in, we're told to put sunscreen on, different ethnicities, it's really difficult. So our blanket policy is just give a good dose of vitamin D to everybody. Don't worry about trying to change doses, anything like that, just give a really good dose to everybody. And it's particularly important before bisphosphonates, because the way bisphosphonates work, which I'll talk about in a bit, they like to grab calcium. And so if you haven't got a good level of vitamin D to start with, they just don't work. Your bisphosphonates can't work. So that's why it's really important to be really, really vigorous, sort of really stringent, and get that vitamin D in. So again, this is just, in case you're wondering about doses. I'm happy to take questions on this later, but I actually think that everybody in this room should be on vitamin D. It's the only, thing that my kids take. I'm a bit annoying about it, actually, but basically everybody should be on at least 400, and if in any doubt, 800, because then that means you can miss a couple of days and it doesn't matter. You can get it in sprays, you can get fortnightly versions. There's not really any excuse for anybody to say that they can't find one that suits them, because there's so many different preparations of it. And again, calcium, I don't think we need to bother about supplementation. Just try and get some in the diet if you can, but you'd be surprised really how little calcium you actually need if you've got good vitamin D levels. So moving on to treatment. So the key thing in the standards of care is actually not all the information in these complicated boxes, but it's that bit there. Clinically significant bone fragility, and you need to treat it, basically. And we used to be quite obsessed with looking at DEXA data and looking at trends and patterns and all this sort of thing. But now, actually, what we say is any vertebral fracture that's sore, so once you've got a vertebral fracture and a bit of pain, we need to treat, or any vertebral fracture that is moderate or severe. So if you remember those pictures of those vertebrae that I showed, anything that's not that top level, so there's just the really small changes, then we would treat that. And again, if you're the sort of person who likes to look at trends, then we would consider adding in treatment for, dropping bone density. And again, if you've got one of those long bone fractures and we're thinking, oh, that wasn't a very big mechanism, if you've been run over or you've tipped out of your motorbike or something like that, then we'll let you off. But if it's anything like the chap I showed at the beginning, bumped his knee into a chair, then I'd be thinking, we need to help you with your bones there. So this is quite a change from, say, 5-10 years ago, in that we're being far more proactive now. And actually, I just came back from Canada last week, and there's a huge push in the US to start bone treatment before that first fracture. So I think if I was giving this talk in, say, 4 or 5 years' time, I think that's where we'll have moved to. So we've always been very aggressive in Newcastle, actually, with bone health and bone treatment. But I think the rest of the country will follow suit with that, and I think this talk will be quite different in a couple of years' time, because I think we'd be almost a little bit like the steroids talk. We'd be saying, once you've started your steroids and you've got used to those, then we're adding in this next, medicine. That's where I see it going. But for the moment, this is what the standards of care recommend. And bisphosphonates have been around for years and years and years. They're a really simple drug, and most of the postmenopausal women are on some form of bisphosphonate. So they're really widely used, cheap as chips, but they're fairly simple. There's nothing exciting or fancy about them. What they do is that osteoclast, that guy I was talking about who chips away at the bones, what they do is they grab hold of him, and if you can see there, they stop him working. So the bisphosphonate's the little yellow ball. And basically that big blue cell, it just clings onto it and it stops it working and kills him. So it lets that chap who's building up the bricks concentrate on working. So it reduces your bone turnover, it reduces the rate at which your bone is taken away. It doesn't build up the bone, but it just stops it being broken down. So what we rely on with bisphosphonates is we rely on that bone being broken down more slowly to let your body naturally build up some bone. If we could find something that helped build up the bone as well, that would be brilliant, but we don't have that other than testosterone, which I'll talk about. So what we're doing here is we're relying on your bones still growing, and that's what's absolutely key here, because we still need some form of growth for the bisphosphonates to work, which I'll talk about in a bit. There was a really exciting paper about 12 years ago that said bisphosphonates improve survival, and people were really quick to jump on it and say, oh, it was a really badly designed study, it was a look back rather than a look forward, there was this, they didn't control for this, blah, blah, blah. But to me, it makes intrinsic sense, because like I talked about before, if your vertebrae isn't straight and your posture's poor and your ribs aren't protecting your lungs and you can't breathe properly, then to me, it seems obvious that those people are going to struggle more than the ones who've got, nice strong bones, nice straight bones. Since that paper was published, we now know a lot more about fat embolism, about adrenal insufficiency, about adrenal crisis, all the other things that are related to nastiness, basically, in DMD. And so I think this paper was way ahead of its time, but what it was actually trying to say is that bones are really important for survival, and I do agree with that. What we don't, unfortunately, have in children, and particularly in DMD, is any really good data to say that bisphosphonates work really well. We've got some studies from osteogenesis imperfecta, so other childhood diseases where there are poor bones, but most of the studies in DMD are really small. It's really hard to do these studies, and particularly now with all the new gene therapy studies and everything else, we've tried for quite a few years now to set up a clinical trial looking at different types of bone agent. But the problem is you need huge numbers, and if you said to somebody it means you can't enroll in any of the clinical trial, people would naturally be reluctant. And so what we're relying on is some quite small study data, but mainly actually just looking at our patients in clinic and seeing the ones that we treat versus the ones that we don't. But what we don't know is, what agent should we use? Should we use oral bisphosphonates? Should we use IV bisphosphonates? How long should we treat for? We know that there are some side effects. I showed you that picture of the bone age X-ray earlier on, and you get these lines. Bisphosphonates, because I said to you that they reduce the bone turnover, they sort of almost stall your bones. They put them into kind of suspended animation. And obviously, if your bones are like that for a long time, then you're at risk of different types of fracture. So we've got lots and lots of challenges ahead of us, I think, with bisphosphonates, particularly if we're thinking about using them, earlier on. But as it stands at the moment, Margaret Zakarin in Australia has produced the only data that we have, which is here, looking at IV bisphosphonate in DMD. And it was a really well-designed, randomized controlled trial. It took her well over 10 years to recruit to because it was so difficult. So this isn't something that we're ever going to be able to do again. So we just need to use this data and take it forward as best we can. But what she really importantly showed is that it improves back pain. And to me, that is absolutely key, because these vertebral fractures can be really sore. And the chap I spoke about at the beginning, he absolutely religiously, without ever failing, rang at 5.5 months after his bisphosphonate infusion to say, I've got a sore back again, can you bring my infusion forward a little bit? And he's the most stoical guy, really, really active, keeps himself, he's involved in loads of different stuff. So I knew it wasn't, malingering attention or anything like that, but he seems to be able to get to 5.5 months, and then he needs his next infusion. And he says it's like a light switch. It's not as effective with everybody, but it definitely is really key for back pain. So whatever it does to your bone density and everything else, it seems to really help your back pain. What it did show is that the boys who were treated compared to the ones who weren't, so the controls are the dotted line, and you can see here, this is their bone density. So we've moved away from using bone density, like I said, as a marker. We tend to now use the actual presence of vertebral fractures. But there's no doubt about it, it improves your bone density, and the fractures that there were, because there were still fractures there, but they were less severe than the ones who weren't treated. But the key questions, again, this was only a 2-year study, how long do we need to use it for? Like I said before, bisphosphonates only work really when you're growing. because otherwise you just get these, sort of static bones. So we don't know what to do once people, become adults, once they transition into adult care. Because that bone age was so delayed in that first patient, he's 7 years behind where we'd think. You assume that somebody stops growing at 17 in a healthy person, but most of the young men in my transition clinic are still growing. So we've kept these bisphosphonates going for a lot longer, but you can't do that indefinitely. So these are going to be conversations that we're going to need to have as we move forward. This was just some work we did in Newcastle a long time ago now. I think it was about 2014 that we did this. And this basically was using oral bisphosphonates. And this showed that you don't prevent those fractures, but again, it seemed to stabilize bone density. So what we tend to do now in Newcastle for those early ones is start them on oral bisphosphonate and then move to the IV a little bit later. I just wanted to mention that because one of the challenges with bisphosphonates is the first dose reaction can be really quite nasty. You get like a sort of a flu type picture. And it puts a lot of these young men and these boys off having it. But what we've seemed to notice in Newcastle is that if you start the oral first, then that seems to get your body used to it basically. So that by the time you have that IV version, you then don't have, you still maybe feel a bit grotty, but you don't have the same sort of horrible flu reaction. And that's probably because bisphosphonates, once they get into your system, they're there for about 10 years. So once you've started it orally, then your body knows it's there, so that when you start probably the more potent version, the IV version, your body's already used to it and it's not such a shock to the system. So it's just worth mentioning because not all centres are kind of, I think, maybe quite as used to using oral bisphosphonate, and I'm not suggesting that that's as effective as IV, but I think for a couple of months first it's quite a good run-in. This was just, I'm not going to talk through this, but this is basically again, another old paper, but by saying as long as you're still growing, vertebral reshaping can occur, so those marshmallows that were squashed can ping back up again. And I think that's really reassuring. This was in Duchenne, so we know that although the numbers are very small, there's only 27 patients in this, there's been some evidence of these marshmallows springing back up again. And that's what we do see on the X-ray. So we do have some proof, although they're very small studies. So what I would say in terms of bone health before we move on to puberty is, at every annual review, the things you need to be thinking about going into your clinic appointment are, thinking about puberty, ask about back pain. People don't always volunteer it because they're not sure if it's muscular, if it's bone, this sort of thing. But get some imaging every year, if you can. Consider bisphosphonates, use them earlier rather than later. Vitamin D just should be, part of your daily routine. And again, encourage weight bearing when you can, even if it's for 2 minutes, 3 minutes, 4 minutes every day. So just going to change tack a little bit now to puberty. And puberty is important for two reasons. It's important because it's the most important thing you can do for bone, but there's also lots of psychological sort of components to pubertal delay that we'll talk about in a little bit of detail as well. So we know that puberty doesn't happen if you're on daily steroids. It's pretty much universal that puberty will not happen by itself on a decent dose of daily steroids. Some of the boys who haven't got the best compliance kind of sneak into puberty a little bit, and it's actually a really good marker of compliance to steroids. But others who are on, alternate day regimens, week on, week off, 10 days on, 10 days off, all the various different ones, some of those go into puberty by themselves. But even then, a lot of those are late or they sort of get stuck in the middle of puberty. So it's something that we almost invariably see with every boy with Duchenne. The reason I'm a little bit obsessed about it is because I think the timing is absolutely crucial. We know that almost half of boys, once they have a fracture, don't get back onto their feet again. And these fractures occur around 10, 11, 12 years. So if we can optimize bones before they have that first fracture, then ideally we can keep them on their feet for longer. And testosterone, without a doubt, is the best agent that we've got to improve bone health. It's an agent that actually, if we think back to that building site again, it builds up the bone, it's anabolic. So rather than just trying to prevent the damage after it's happened, we're doing something about it at the beginning. And that's why it's so important, puberty. There's obviously, and it's really important, the psychological impact of puberty, but first and foremost, it's actually really a treatment for your bones, if that makes sense. So just looking at this graph here, the male line obviously is the one we're probably thinking about in the majority of cases at the top here. And you can see you get your peak bone mass by kind of 25, 30 years-ish. it's really important, if you think about it, where you get your peak to be, because after that, sadly for probably the majority of us in the room, it's a downhill slope thereon. But if you can build up that bit at that crucial point at puberty, you can see there it over doubles your bone mass during puberty. Bones don't just get longer, they get wider, they get thicker. You know, every component of a bone changes during puberty, and that's what we need to be doing. And this just shows you here, this graph. This is a bone density trend that I was talking about before. And you can see it's gradually decreasing until it gets to 12, and then you can see that massive drop-off. And this is age-adjusted compared to the population, and all that's showing you is that this person hasn't gone through puberty compared to the rest of the population, because those age-adjusted figures we would expect, you know, the trend, you would expect your bone to increase, but instead it's not, it's plummeted. And that's why puberty is so important. Testosterone not only accelerates, you know, growth. We know that the average boy gains about 30 centimeters during puberty, you know, a whole ruler. It's a huge amount of growth. But it also increases lean muscle mass and strength. Clearly, you get the development of your male sex characteristics and virilization, which I don't want to, you know, underestimate the importance of. But also, it actually increases your red cell production as well, which some people don't think about. But I think for this population, it's particularly important, again, because, as you know, your red cells carry oxygen. And so it probably has a significant independent effect on your FVC and your breathing as well. So again, I'm not going to talk about this, but hopefully what you can see is testosterone is, this is a picture I had to draw for my thesis a long time ago, and it actually brings me out in anxiety when I look at it. But this testosterone here, you can see like the arrows are in all directions here. Basically, testosterone is at work affecting your muscles, your bones, your growth plate. The excess gets converted to estrogen, and that's how our bones are improved. So we need good levels of testosterone so that you've got enough testosterone to convert to estrogen, the female hormone, which then gives you a surge of growth hormone and then directly affects your bones. So that's how it actually works. It's not testosterone itself that's so good for our bones, it's the estrogen. But males don't make estrogen, so they need the testosterone first. And that's why puberty and that big surge is really important. So we spent quite a few years in Newcastle trying to work out how best to take these boys through puberty. We had lots of different ways of doing it. We were slapping on gel, we were giving tablets, we were sporadically giving injections, we were starting early, starting late, giving people a break, not a break, and we didn't really know what we were doing. So we thought we'd look at it sort of systematically, and very kindly Duchenne now, quite a long time ago now, it was probably, I'm looking at Kathy, it was about 2016 I think we started. No, Duchenne now, when we started with the funding. I think it was about 7 years ago now, actually, that we initially had this money. And what we did was really simple. We just chose one regimen and took 15 boys through puberty. But we did it systematically, and we also looked at muscle MRI as well. And so from that, we were able to collect all the data really neatly and know that we were doing the right, you know, the same thing for every patient. And what we found out was that, sorry, these are just the things that we looked at, which we don't need to go through. What we found out was that most of these boys were coming to us at around 13 years, 14 years, and that was probably because Newcastle's got a brilliant muscle team. You know, they're very, very engaged, very enthusiastic, and probably refer quicker than most centres around the country. So what we thought was sort of reasonable was take any boy 12 and over who was just being referred to us naturally. So I'm not going to talk you through all this detail, but the important things to see here is that at baseline, the boys were just under 14, but again, their bone age is all delayed. Can you see that there? There's 9.4 at baseline. So they've got this significant gap between their actual age and their bone age. And they'd all been on steroids because that was one of the inclusion factors that we wanted to look at, and fairly standard doses of prednisolone. The main outcome for this study, because I wasn't convinced at the time that giving injections every 4 weeks was the right thing by these boys. It seemed like quite an ask on top of everything else, you know, that they've got to deal with. So I wanted to know whether it was actually what they wanted. You know, is it okay with them? And so we looked at this thing called the TSQM, which is a treatment satisfaction questionnaire. And hopefully you can see here, there are 4 different domains, and then there were different questions that we asked among it. It's not really important to go through these in turn, but hopefully you can see here that 1 was extremely dissatisfied and 7 was extremely satisfied. And you can see here all these numbers are at the top. apart from this poor chap who did it the wrong way around by mistake, but we had to keep his data in. But you can see here, overall, people were happy with it. You know, it was what they wanted. And importantly, it worked. So after 2 years of gradually increasing doses of testosterone, their testicular volume, once we'd stopped the testosterone, increased. Keeps doing this. It's got a mind of its own. Sorry, one second. Just switch ways around now. Oh yeah, I'm definitely not going to press that pointer again. So you can see here that what happens when you give 2 years of testosterone is that the brain wakes up. So once you stop that testosterone, the brain then says, hang on, I quite like that. I needed it for lots of different things. And in all of these boys, they produced their own testosterone after 2 years. So what we did is we basically took them through puberty for 2 years. So, you know, they developed some facial hair, they grew, they, developed a bigger willy, they were happy with themselves, their confidence levels improved. But what doesn't happen when you're actually giving testosterone is the testes don't grow. And that's because you're giving the testosterone via an injection, so their bodies aren't making it themselves. And I think that was a really important concept that we hadn't really realised was a big deal to these guys, because they were starting to worry that their balls weren't getting any bigger and everything else was. But as you can see here, they do grow. So once the testosterone was stopped and those brain signals then kick in, the cells that make testosterone then start churning out testosterone, and then your balls get bigger. That's basically what happens. And so it worked. You know, giving 2 years of testosterone, gradually increasing, seemed to be the right thing to do. And again, this isn't really important to you, apart from the green on the left-hand side of that graph, these testosterone levels. The blue line is an adult line where we'd want testosterone to be. So 6 to 9 months after we stopped testosterone, they've still got the right level of testosterone, which was key for us. What was a little bit more exciting, and we guess hadn't expected, was that we seemed to be able to improve the muscle as well. So I don't know how much you know about muscle MRI and fat fraction and things, but there's been a lot of work done particularly in Newcastle and London over the last few years, using muscle MRI as a marker of disease severity and progression, and gradually a lot of the clinical trials are starting to use it because it's very objective. You know, it doesn't depend on the boys wanting to take part in a walking test or something. But what we know is that in the teenage years in Duchenne, you would expect the fat fraction to increase. You know, they're not in that improvement phase, they're starting to go in the sort of the decline phase, and you would expect those muscles to become infiltrated with lots of fat. But what we managed to show was that instead of infiltrating the muscles with fat in these 2 years, the healthy muscle built up. And on the left-hand side, in the green, that's the healthy muscle, so the contractile surface area of the muscles in the arms and the legs. And you can see after 2 years that it had increased, and that's a significant increase. And so not only are we know that testosterone helps bone, and we know that it makes the boys look like they want to look like, gives them a little bit of extra height, but actually we were arguably doing something for their muscle strength as well. And this, again, was another surprise. This is another component of the muscle MRI called T2 relaxation. But what that sort of shows is the level of inflammation or the level of disease activity in your muscle. And we showed that that was a little bit lower as well. So it's not a wonder drug. It's not something that we're going to say you must take for your muscles. But again, it's got these additive benefits. Probably the most important part of all, though, was that when we did some proper analysis on the quality of life work, it statistically increased these boys' quality of life. So even though they were older, and you could argue that a lot of them had gone off their feet during this time and were perhaps less able to walk as far and things, they felt better about themselves. And these were the key themes that came out when I did some of the interviews. They wanted to be like their peers. They wanted to talk about the same things as their peers were talking about. And I noticed it particularly in the 15 boys, but I see it in clinic as well. When these boys are referred to me to start talking about puberty, they're mortified, as all kids are. But by the end of the 2 years, some of them come in without their mum and dad, to the clinic room. They ask me questions. They're not afraid to have their voice heard, and it's a really important change that is part of growing up. It's nothing specific to DMD. It's, that transition period from being a child to being an adult, and it's absolutely vital for so many reasons. But the other thing that they said to me, which actually I found really difficult to take, was we just trust healthcare providers. So if you say it's the right thing to do. And that actually gives us a huge sense of responsibility. And I think that's why research is so important to do, so that we know these are the right things, to be doing. But they also said, despite the testosterone, they still felt that this was a difficult topic to talk about. And I completely understand that. And we'll talk a little bit about that, later. So this work, this is the most sciencey, part of the presentation, but it was just to show you that we have done some work into testosterone. We know it's well tolerated. We know that it produces, the boys produce their own testosterone afterwards. There doesn't seem to be a deterioration in the skeleton while the boys are on testosterone, which again, we would expect. And it does seem to do something good in terms of muscle. What we then did, and COVID unfortunately made it very, very difficult, but we then followed these boys. So they'd had their 2 years of testosterone treatment, and we then followed them up for another 3 years afterwards. And what you can see here in all these numbers is one patient needed to start testosterone before the final follow-up, so before the end of that 5 years. And then when we saw them at the final follow-up, we recommended them to restart in another 5. So I think the key thing here is it's brilliant that these boys' axis, as we call it, so the hypothalamic pituitary gonadal axis, is being kicked in, but probably because of the ongoing steroids, it's not going to be enough in the long term to maintain testosterone levels, So it's really important to keep monitoring these testosterone levels and to have, ongoing communication and talks in clinic. And again, unfortunately, what we showed during that 3 years of follow-up is that those muscle improvements that we'd seen while the boys were on the testosterone weren't maintained, and things started to drift and follow the normal natural history pattern again. So there was an increase in that fat fraction and a decrease in that healthy muscle going forward. Not to below where they would have been otherwise, but just that unfortunately that improvement didn't carry on. So what we showed basically from the extension study is, unfortunately, that inevitable decline we can't reverse just with 2 years of testosterone. But what we did say is, we know that it helps bone health, we know that it helps muscle, and we know that it helps well-being. So we need to be really careful here to keep monitoring these testosterone levels. And should we be thinking about it earlier, or should we be thinking about it just as a continuation? And I think those are the difficult questions that I'd like to look into more, going forward. How do we best find this balance? If we found this improvement, surely it's mad to stop. But then you could argue that you need that for fertility, and that if you look back at that previous slide, 8 out of the boys were still maintaining their own testosterone, and that's surely got to be better than monthly injections. So it's a difficult one, and I think the only way at the moment that we can really find the answer to that is by regular follow-up in clinic, and by asking the boys how they're feeling, because a lot of the time actually that correlates. If they just say, I'm just feeling not right, my confidence is just a bit funny, often that's when the testosterone levels start to go down again. So the standards of care basically there's not a lot of information about puberty, but they say, start to talk about it in clinic from 10 to 11 years, assess puberty in all boys 12 years and older, and refer them if there's no signs of puberty. So I think most places around the country are doing that. We would advocate in Newcastle as early as you can, so that we can have time to have these conversations with the boys, because I regularly have boys looking down at the ground, embarrassed and red when I start to produce the testosterone beads and things. That's enough just to make them, run away. But by the time I've banged on about it for, the next 3 appointments, they're like, oh my God, she's got those beads out again. And, by the time I actually need to use them, they're normally relatively, comfortable about it. And so I just wanted to bring this up because I think this is really difficult. And of all the things that we expect people to do in clinic, they're coming into a hospital environment which isn't nice anyway. Often it's associated with previous hospital stays and things. It's stressful at the best of times, parking, and wheelchair access is often rubbish and things. You come into clinic and you've got a 15-minute appointment, and I bring these beads out and expect somebody just to whip their trousers down. And it's rubbish. And if there was any other way we could do it, we would. But actually, it's really, really important, and it correlates so well And, you know, that simple 5-second examination tells us all we need to know. And I mean, I was mortified once. Most people have heard this story, but my daughter wore these beads to nursery once. And I went to pick her up, and the lady said, "Oh, it's an unusual necklace she's got on." Oh, God. And didn't dare say what it actually was because, you know, clearly I'd used them as well. I mean, I do wash them, but obviously I don't know where she'd managed to get them from. But what we're wanting to do is to get this to become not quite so scary for boys. And so actually, Duchenne UK have very kindly just given us a little grant to make a video. And I'm hoping that we can get this video sort of easily circulated on the web so that people can watch it with their kids, you know, with granny, with whoever they feel comfortable watching it with, so that by the time they come to clinic age kind of 9, 10, and we flash these around, they're like, oh, that's what they look like in real life, rather than, you know, that instant panic of something new, something different. So hopefully we're going to be able to get, you know, boys to a point in the future where it's not so intimidating, because I think it's a really difficult balance between waiting till somebody's old enough and comfortable enough to talk about it versus perhaps trying to push it a little bit quicker because we think that might be good for their bones and their muscles. So it's, you know, it's a really difficult one, and hopefully by making some, you know, some more leaflets, videos and things like that, and getting the discussions going in clinic, we can make it less frightening. Sorry, it's not working. So yeah, so just to go, you know, future direction, just to finish off with, I've said, you know, we need bone protection early, but there is this move now for sort of primary prevention, and maybe even before the first fractures, you know, happened. Leanne Ward in Canada did some lovely work in denosumab, and we thought this is going to be great, it's going to be the next big thing. And then unfortunately, the longer term follow-up has shown some quite nasty side effects. So, you know, that's back off the table again. So we've really got not a lot to work with at the moment, other than to try and bring these things I've talked about in a little bit earlier. Vamorolone, you know, we don't know what's going to happen. That's you know, an unknown at the moment. Certainly I've had one referred to clinic over the last year with pubertal delay, so we know it's, you know, it's not perfect by any stretch. We don't know if some will go through puberty, some won't, and that'll just be a question of, you know, waiting and seeing, really. And then once they become adults and they stop growing, we then have a few different, you know, medicines that we potentially can use. But again, those are, you know, some of them are difficult, some of them are daily injections. So we don't know where this field's going to, you know, going to land up. But there are definitely things happening. But I think the key thing here is this early action. It's not going to be a change of what we use. It's going to be when we use it. And just on that, Jared in Glasgow with Professor Bray in Liverpool is looking to do some interviews with parents and their children regarding timing of treatments to prevent first fracture. And she'd be really keen. I know it's been quite heavily advertised on the Duchenne UK website, and hopefully Action Duchenne will be able to advertise it as well, because Lucy's really keen to get a range of participants to look at this, because what we're hoping to do, I'm working with her on it, is basically get that balance right, you know, find out when we should be starting these agents. And so, as I say, her email's there, but if you want any information about it afterward, just come and find me. It's not a tricky interview or anything, it's just short, but it's just to try and get some views of people. So the last couple of minutes, I promise, is something that's particularly close to my heart, and it's not really the title of this talk, but I think it's just something that I want people to start thinking about, and I'll explain why in a minute. So when we've done the follow-up study from the pubertal delay, what we found was that inhibin B, which is one of the markers of your cell function in your testes, so suggests how well you're going to be able to produce sperm, increases during puberty. That's what happens in normal puberty, so, you know, it makes sense for it to happen. But what we found was really quite reassuring with respect to, you know, fertility. And we know that there are case studies of men having had children with DMD, but I think things are going to shift, you know, as we're getting much better multidisciplinary care, much better treatments. You know, men are living longer, they're feeling better. I think the natural shift is going to be that some of these men are going to be thinking about children, thinking about fertility, but also thinking about sex. And it's really important that we don't forget this group. So I've been very, very lucky, because I've known some of the boys in clinic for a long time now, and I've transitioned, you know, them with them. Some of them have been very, very brave over the last few years and come to me with their concerns and with their worries. And one of the things that they specifically want to talk about is, you know, how do I have a relationship you know, it's impossible. It's really hard. And one of the stories that was the closest to my heart, almost moved me to tears in clinic, and I'm a bit of a tough old thing, it doesn't happen very often, but was this chap who wanted a girlfriend. He'd met somebody and he wanted to take things further, but because of the way the house was adapted, his front door was through his bedroom. And he said, I can never invite her to my house because the world and his wife comes in our house all the time. I can't have any privacy at all. And he mentioned it to his mum, and his mum just said, what on earth, she can come and sit in the lounge with us. And he just couldn't, get that across at all. And so we eventually managed to get one of our support workers to have a chat, and they've now changed the entrance of the house so that he does have, private space. But this got him to the point of almost dropping out of his college course because he was so, frustrated by it. And he just said, what is the point in me, carrying on as a young man if I can't do all the things that my peers are talking about? And he just felt so insignificant and inadequate. And I thought, gosh, it's really, really difficult. And it would never have occurred to me. He couldn't just take her upstairs or, do whatever. He was so restricted by the physical bounds of the house that he felt embarrassed to bring her home. And we've ended up doing some focus group work in Newcastle, and some really surprising things came out of it. It was a national, focus group, so this isn't just people from Newcastle. But one of the things that came out was, the issue of sex workers and paid sex and the challenges around these things. And I really want this to be not such a taboo subject to talk about. And I don't know the best way to do it. And, I had a lady from America contact me a couple of months ago to say, I've heard you've done some work in this. This is awful. And I sort of, said, well, why is it awful? And said, oh, because you shouldn't be encouraging things like that. And it was a really bizarre reaction because, I didn't understand what part genuinely that she said we shouldn't be encouraging. But what her attitude was that we shouldn't be encouraging testosterone levels to the point where these men are able to think about wanting physical relationships because they're unable to have them. And, there are so many ways that these things can be facilitated, but it's a real challenge. And one of these focus groups in particular was a real eye-opener because one of the men in it, and he's very open about it, obviously I'm not going to name or anything, but he actually said, if you ever come across anybody who wants to go down this path, put them in touch because I'll explain. But he said it was like scheduling a work conference, to actually arrange sex. And he said, it's in the family diary, and, made a sort of joke about it. But he said there's only certain carers that will, put up with helping him. He said, it needs to be at a time where it's a specific lady, because he said, he knows that she'll be the one who'll be, open-minded enough about it. And he said they need a specific hoist and they have to borrow it. And I just thought, goodness, it's a whole new level. But it is something that I think going forward is going to be an issue. And I'm not saying that everybody wants to go to that length, but even to the extent of, not necessarily thinking about these things with other people, but, these men by themselves, or with their carers want some pleasure. And I just think that going forward, it'll be really interesting to see if we can move it to a place where it becomes commonplace to have these conversations in clinic. And I just wanted to use this forum because I think a lot of the parents, when I talk about these things in clinic, are quite shocked. And it's a really difficult one because a lot of these men are very reliant on families, on carers, and trying to get the balance between, having personal space but actually needing somebody in that personal space to help you is a real challenge. And when you look at the literature on it, there's nothing. There's absolutely nothing. There's loads of information on sort of sex post-spinal operations and post-spinal injury. And that's a very different scenario because those people have previously had an able body and now don't. But these are people who are having to adjust on, probably an annual basis with a change in their body, in their change in their physical function. And one of the guys said, although it's very difficult wanting relationships and dealing with rejection, I'd much rather have that than be stuck in a prepubescent state. And that was the general consensus on these focus groups, that, they want testosterone, they want to feel like a man, but actually, most of them asked for sex therapist, contact details, or for some, forums to talk about these things. And obviously, naturally, some families talk about stuff more than others, but the general consensus was, like any illness, like any physical disability, there will be a wide range of us, and we want somebody to accept us for who we are, and whether that's, a gay relationship, a straight relationship, no relationship, I think we have to try and move forward somehow to be able to make this commonplace to talk about. So just to summarise, we know that, impaired bone health and fracture are really common in Duchenne, and that the underlying muscle problem and steroids are the two main contributory factors. Getting in and getting those vertebral fractures seen and treated early is key going forward. And again, as I said, addressing puberty and giving testosterone is probably the most important thing for the bone health. And what we're hoping to do now, and we're already moving forward with, is to think about the guidance for the next step. So once these men, stop growing, what do we need to do? Because there's so many unanswered questions, in this field. So just want to thank all my collaborators, people who've very generously funded projects over the years. That's Jared in the middle, who probably lots of you already know, and then Shuka, who did lots of work, and then Tim Cheetham at Newcastle was instrumental.